Hey everybody, Dr. O here, and welcome to this video on urinalysis exercises. We'll be interpreting some patient history and urinalysis results and seeing if we can figure out what's going on. So let's get started. So for our first patient, we have a 67-year-old male who is complaining of frequent urination, vomiting, and swelling in his face and his feet. All right. He also notes that his urine seems to be foamy. Well, that's interesting. The patient has a long history of diabetes, which at times has been poorly controlled, as well as a long history of hypertension. So we have him give us a urine sample, and we notice that it is dark yellow, and indeed it has a foamy quality to it. So then we put in our dipstick, and these are the results that we get. So I'll give you a second to take a peek at that. And you might have noticed that we've got this right here. So as far as appearance goes, we know the dark yellow color is a problem, as is the foamy quality. But as far as the dipstick goes, this is our big area of concern right here, this protein in the urine. That shouldn't be there at all. Now, if we come down here, people might be a little bit alarmed about this, but if we come over, we can find that color right here, so that's not an issue. And our pH is coming in about normal as well, because remember there's a wide range of pH and there's also a fairly wide range of specific gravity, which can tell us a little bit about what's going on with the patient. But as far as this patient goes, it's the protein that we are concerned with. So let's answer a question about this patient. So we just found that we have protein in the urine. Why is protein in the urine of concern? Is it because it indicates uncontrolled blood pressure? It indicates a diseased pancreas? It means that the glomerulus may be damaged, or does it mean that there is high blood calcium? Well, the answer is that it means that we may have damage to the glomerulus, and that's a problem because the glomerulus is the unit that is going to be doing filtration for the kidneys, and if it's damaged, then our kidneys are no longer capable of doing what it is that they're supposed to be doing. Because remember, proteins are huge molecules, and they're not supposed to be spilling out in the filtrate during the filtration process in the renal corpuscle. Here's our second patient, a 36-year-old male. He is complaining of fever and chills for a couple of days. Upon physical examination, he demonstrates tenderness in his back over the right kidney. So we give him a little cup, and he gives us a urine sample in turn, and we notice that his urine is yellow and it's turbid. And when we put the little stick in, these are the results. And the thing that may be obvious about his urine is that the turbid quality is of concern. And when we look at the dipstick, the thing that jumps out is that he has leukocyte esterase showing positive on his dipstick. So let's answer a question about this patient. So we got a positive for leukocyte esterase on our dipstick. What additional test could you run to confirm that this patient does have an infection? Would it be looking for red blood cells in the urine? Would it be running a test that would show elevated platelets in the urine? Would it be looking for glucose in the urine? Or would it be looking for white blood cells in the urine? Well, hopefully you said it's white blood cells, because wherever they are, that indicates that there's some sort of an infection somewhere. So you'd actually just look at the urine under the microscope and see if you couldn't see some white blood cells. In this scenario, we have a 43-year-old male complaining of pain that wraps around his right side and radiates into his right testicle. Wow, that's no good. This morning, the pain was so intense that he was vomiting. During the visit, you notice he is unable to sit still due to the excruciating nature of his discomfort. Poor guy. He does give us a urine sample, and we see that it is dark yellow and cloudy. Got a couple of things there. And then we put the dipstick in, and these are the results that we got. So just based on how it appears to our eye, we know that the dark yellow color and the cloudy appearance are of concern. And when we look at the dipstick, the thing that jumps out is that he has blood in his urine. So let's answer a question about this patient. So given the patient's history, his appearance at the time of the visit, the fact that we have blood in the urine, we're leaning towards a kidney stone. So what additional test could you run that would confirm that this patient has a kidney stone? Would you want to take an image such as an ultrasound or an MRI or maybe even an X-ray? Or would you run a full blood chemistry panel to see what else is going on in his body? Would you run a differential white blood cell panel to see if he has some sort of an infection? Or would you do exploratory surgery? Well, hopefully you said that let's go in and take a peek and let's just see if we can't see that kidney stone and where it might be. This patient is a 27-year-old female and she's complaining of excessive thirst and urination, which she has noticed for the past couple of months. When prompted, she also admits that her appetite has increased. Now, I know a lot of people at this point would be concerned that she is pregnant. You'd want to run a pregnancy test, but let's just go ahead and run the urinalysis first and see if we have something that directs us away from the pregnancy option. So when she gives us a urinalysis, we see that her urine is yellow and clear. And then when we do the dipstick, we see that it gives us these results. So what you might be noticing is that this patient has elevated ketones and elevated glucose in that urine. So these two together, particularly these two together, would direct us away from pregnancy. Well, let's answer a question about this patient. So we have a patient who has elevated levels of glucose as well as ketones in the urine. What does that tell us? What does it tell us? So the glucose is not being metabolized, but we're making tons of ketones. Where do we make ketones? What do we make ketones from? What macromolecule? Well, we make ketones from fats. We're breaking down fatty acids in order to get to that acetyl-CoA that we can drop into the Krebs cycle. But because we can make a lot more acetyl-CoA, breaking down a fatty acid, than we can feed into the Krebs cycle, many of these get converted into ketones so that we can then access them later. So all the while the body's ignoring the glucose. So if we're not metabolizing glucose, and we are metabolizing fat, what do we think this patient has? Do they have gallstones? Do they have a glucagon deficiency? Is it metabolic syndrome or is it diabetic ketoacidosis? Well, this patient has diabetic ketoacidosis. So this is a patient who is not utilizing glucose but is having to break down fat because there's not enough insulin allowing glucose to enter into the cells, and so the cells are trying to get energy by breaking down the body's fat stores. This patient is a 62-year-old female, and she's complaining of fatigue and abdominal pain. And she's noticed over the past few days that her stomach seems to be swelling, and the whites of her eyes have a yellow tint or a yellow cast to them. So she gives us a urine sample, and we see this urine is very, very dark, and it's clear. And so we do the dipstick, and this is our result. So what are we noticing about this patient? Well, it might be subtle, but this patient, I mean, we have obviously issues with that dark yellow urine. But when we look at the dipstick, what are we noticing? We're noticing this right here. This patient has bilirubin in their urine. So we have to ask ourselves, where does bilirubin come from? So let's go answer a question about this patient. So we have a patient who has bilirubin in the urine. What organ may be damaged? Would it be the spleen? Would it be the thymus? Would it be bone marrow, or would it be liver? Well, it would actually be the liver. Now, the spleen, you might have been inclined to say the spleen, but the spleen is doing its job if it's making bilirubin. Because remember, the spleen, we get bilirubin, let me say it this way, we get bilirubin from the breakdown of red blood cells. And it's the job of the spleen to remove damaged old blood cells out of circulation and to break them down get them back down to their amino acids. That's what the globin part is. And then break down the heme part into iron and bilirubin. So if we have bilirubin, then that means that the spleen's doing its job, but it's the job of the liver to pull bilirubin out of the blood and utilize it. So it's going to be the liver that is damaged in this case. And you might be asking, well, where is the swelling coming from? When the liver gets damaged, it creates a type of a hypertension, and fluid will start to accumulate in the abdomen in a condition called ascites. And so that's the swelling that was of concern in the abdomen. And then the yellow cast to the eyes, when you have elevated levels of bilirubin in the blood, it can spill into the urine, but when it's in the blood, it will cause the skin to turn yellow and the eyes to turn yellow. It's easily seen in the eyes because of the whites of the eyes, but that's called jaundice. And we're going to see our last patient of the day. And it is a 21-year-old male, and he's complaining of fatigue. He doesn't have any other symptoms, so he's got no fever, blood pressure's normal. But the fatigue is making it difficult for him to attend classes at nursing college. So we just start with a urine sample, and he gives us a urine sample, and we can see it's dark yellow, but it's clear. And so we do the dipstick, and these are our results. So what do you notice? Well, we don't notice anything with our white blood cells, so we're not guessing any infection. Urobilinogen looks fine, no protein. pH looks normal, within normal range. No blood. Specific gravity, specific gravity is a little on the high side. Ketones, nope. No bilirubin, no glucose. So the thing that we notice is that we do have this dark yellow urine, which can be indicative of dehydration, and we can back up this this suspicion, given nothing else, with the fact that he's got a very high specific gravity. So basically, he's got a lot more solutes in his urine than he really should, which basically means he's dehydrated, and that can leave you feeling kind of yucky. So let's answer a question about this patient. So when we're looking at specific gravity in urine, we're comparing the amount of solutes in our urine to the amount of solutes in pure water. Pure water has no solutes. It has a specific gravity of 1. And so the further away from 1 we get, the greater our number is than 1, like 1.03, then we're getting more solutes in our fluids. And that basically means that we've got a high concentration of solutes and maybe not enough water. So that kind of leads us down the path of dehydration. So keeping that in mind, what advice would you give this nursing student? Would it be to take additional vitamin C, increase protein intake, drink more water, or eat more beets and asparagus? Well, although I like beets and asparagus, the correct advice would be drink a lot of water because you're dehydrated. And with that, we are done. Thanks for watching.